Welcome to this practice review covering the ATI Maternal Newborn Exam. We'll break down why the right answer holds up, why distractors fail, and the principle behind each item. This session works through questions covering high-risk pregnancy care, stages of labor, postpartum complications, newborn assessment, birth control methods. Just a reminder, our site has free exam guides and plenty of practice questions to help you master your ATI Maternal Newborn Exam. Everything you need is just a click away, with the link waiting for you in the description below. So go check it out, and remember, study smarter, not harder. Alright, let's get started. Question 1. A nurse is assessing the fundus of a client one day after a vaginal birth. Which finding should the nurse identify as expected? Your options are A. Fundus about 1 centimeter below the umbilicus. B. A fundus that cannot be located. C. A boggy displaced fundus. D. Fundus 3 centimeters above the umbilicus. Which one is it? Pause the video if you need more time. The correct answer is A. Fundus about 1 centimeter below the umbilicus. A is correct because the uterus descends roughly 1 finger breadth per day after birth. So by the first day, the fundus is expected to be about 1 centimeter below the umbilicus. B is wrong because the fundus is still palpable in the early postpartum period and becomes unpalpable only later. C is wrong because a boggy displaced fundus is an abnormal finding that signals atony or a full bladder. D is wrong because a fundus rising above the umbilicus suggests a full bladder or poor tone, not normal involution. After birth, the uterus must shrink from about 1,000 grams back to roughly 70 grams, dropping from the xiphoid down behind the pubic bone in about 6 weeks. Clinicians track this predictable reversal as a daily vital sign of postpartum recovery. When the placenta detaches, it leaves an exposed bed of spiral arteries too large to suture. Instead, the muscle of the uterus contracts and mechanically pinches those vessels shut, a living ligature that keeps bleeding under control while involution unfolds. Mechanically, 3 things happen together. Muscle fibers shorten and stay contracted. Individual cells shrink by digesting their own excess protein rather than dying, and the endometrial lining regrows from its base while shedding debris as lochia. The visible sign of all this is fundal height dropping about 1 finger breadth or 1 centimeter per day. Right after birth, the fundus sits near the umbilicus, briefly rising slightly within 12 hours. From day 1 onward, it descends about 1 centimeter daily. So day 1 is 1 centimeter below the umbilicus. Day 3 is about 3 centimeters below, and by around day 10 it has dropped behind the symphysis pubis and can no longer be felt. 3 different findings point to 3 different problems. Boggy means poor tone and risk of hemorrhage. Displaced means the uterus is pushed off midline, usually by a full bladder. And subinvolution means the size isn't shrinking on schedule despite good tone. A firm, midline fundus tracking 1 centimeter per day is exactly what a normal exam should show. Question 2. A nurse is caring for a client who has severe preeclampsia. Which finding should the nurse report to the provider immediately? Your options are A. Mild ankle swelling. B. Reports of fatigue. C. Severe headache with epigastric pain. D. Blood pressure 118/74. Take a second. Which answer would you pick? The correct answer is C. Severe headache with epigastric pain. C is correct because a severe headache with epigastric pain can signal worsening preeclampsia and an impending seizure. So the nurse reports these findings right away for prompt treatment. A is wrong because mild ankle swelling is common in pregnancy and is not the urgent warning that headache with epigastric pain represents. B is wrong because fatigue is a frequent, non-specific complaint and does not carry the same warning of a coming seizure. D is wrong because A, blood pressure in this range is within normal limits and is reassuring rather than concerning. Preeclampsia isn't defined by protein in the urine. It's a vascular disorder that begins months before any symptom appears, and understanding that origin explains why certain complaints are medical emergencies, while others are background noise. Early in pregnancy, fetal cells are supposed to remodel the mother's spiral arteries into wide, low-resistance channels. When that remodeling fails, the arteries stay narrow. The placenta is underperfused, and it releases factors that injure blood vessel linings throughout the mother's body. Once the endothelium is damaged, the injury goes systemic. Vessels leak and constrict. The liver capsule stretches. The kidneys filter loses selectivity and spills protein, and the brain loses its ability to auto-regulate blood flow, setting the stage for seizure. The tested skill is separating uncomfortable from predictive. Puffy ankles and fatigue are near universal and mean little, but a headache unresponsive to medication, visual disturbances, or pain under the ribs signals cerebral and hepatic injury that can precede a seizure. Gestational hypertension, preeclampsia, and eclampsia sit on one continuum, moving from pressure alone to pressure plus organ injury to seizure. Recognizing the warning symptoms early is what keeps a client from progressing along it. Question 3. A nurse is performing Leopold maneuvers and then auscultates the fetal heart tones. Where should the nurse expect to hear the heart tones most clearly with a vertex presentation? Your options are A, below the umbilicus, B, over the upper chest, C, near the client's shoulder, D, above the umbilicus. Before I reveal it, which one do you think is right? The correct answer is A, below the umbilicus. A is correct because with a vertex presentation, the fetal back lies low, so the fetal heart tones are heard most clearly below the client's umbilicus. B is wrong because the upper chest is not where fetal heart tones are auscultated. C is wrong because the shoulder area is not a location for hearing the fetal heart tones. D is wrong because heart tones above the umbilicus suggest a breech presentation, not vertex. Leopold maneuvers are 4 abdominal palpations that reveal how a fetus lies inside the uterus, taking just a couple of minutes with nothing but warm hands. Because nearly every labor decision depends on fetal orientation, this hands-on skill lets a clinician read the situation immediately, even without an ultrasound at the bedside. Fetal heart sounds transmit most clearly through the fetal back, because the back presses firmly against the uterine wall with the least fluid or limb in between. That's why the maneuvers do more than name a presentation. They tell the examiner exactly where to place the stethoscope. In a vertex presentation, the head is down and the back curls low to one side, so heart tones are heard below the umbilicus on that side. In a breech presentation, the fetus is inverted. The back rides high in the fundus, and the tones shift above the umbilicus. Position of the sound simply follows position of the back. Picture a nurse examining a client at 38 weeks. The fundus holds a soft, irregular mass. The buttocks. The maternal left holds a smooth ridge, the back, and a hard, round, palatable head sits over the inlet. The transducer goes below the umbilicus on the left, confirming a vertex presentation, left occiput anterior. The terms that get confused are lie, presentation, position, and attitude, and keeping them separate solves most of the difficulty. Only presentation determines whether heart tones sit above or below the umbilicus. So heart tones found high at term should prompt confirmation of a breech lie rather than being recorded and forgotten. Question 4. A nurse is teaching a client who has iron deficiency anemia about taking ferrous sulfate. Which instruction supports the best absorption? Your options are A. Take it with tea, B. Take it with an antacid, C. Take it with orange juice, D. Take it with milk. What's your answer? Commit to one before I continue. The correct answer is C. Take it with orange juice. C is correct because vitamin C enhances iron absorption. So taking the supplement with orange juice helps the body use the iron and correct the anemia more effectively. A is wrong because compounds in tea interfere with iron uptake, working against the goal of treating the anemia. B is wrong because antacids lower stomach acidity, which decreases iron absorption. D is wrong because the calcium in milk binds iron and reduces how much the body absorbs. Iron supplements only work if the gut can actually absorb the iron, and that absorption step is the real bottleneck in treating deficiency. Iron mostly arrives in the ferric form, which the gut absorbs poorly. Acid in the stomach converts it to the ferrous form, and only then can the transporter in the duodenum let it cross into the bloodstream. Vitamin C acts as a reducing agent, keeping iron in that absorbable ferrous state and forming a soluble complex that resists breaking down as it moves through the gut. That's why orange juice, not water, is paired with an iron tablet. Inhibitors work by the opposite logic, each blocking a different part of the pathway. Tea and coffee bind iron into complexes too large to absorb. Calcium competes directly at the transporter, and antacids raise stomach pH, so the reduction step never happens. The teaching point isn't that milk or tea are unhealthy. It's timing. Take the tablet with citrus juice between meals and keep dairy, tea, coffee, and antacids about 2 hours away. Question 5. A nurse is caring for a client with a possible ectopic pregnancy who suddenly reports sharp shoulder pain and feels faint. Which action should the nurse take first? Your options are A. Notify the provider immediately. B. Offer a large meal. C. Encourage the client to walk. D. Apply heat to the shoulder. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Notify the provider immediately. A is correct because sudden shoulder pain with faintness suggests the ectopic pregnancy has ruptured and is bleeding internally. So the nurse notifies the provider at once for emergency care. B is wrong because offering food does nothing for internal bleeding and could delay needed surgery. C is wrong because walking raises activity and oxygen demand during possible internal bleeding, which would worsen the client's condition. D is wrong because the shoulder pain is referred from blood irritating the diaphragm, so applying heat treats the wrong problem and wastes time. A ruptured ectopic pregnancy causes bleeding into the abdomen, and that bleeding produces a strange, telltale symptom far from the pelvis, shoulder pain. Understanding why requires following the anatomy, not the location of the pain. The diaphragm is supplied by the phrenic nerve, rooted in the 3rd, 4th, and 5th cervical segments, the same neighborhood that supplies skin over the shoulder. When blood from a ruptured tube irritates the diaphragm, the spinal cord misreads the signal as coming from the shoulder instead. This is the care sign. 3 conditions cause early pregnancy pain and must be told apart. Threatened miscarriage stays midline with bleeding and a closed cervix. Torsion causes severe one-sided pain with vomiting, but no shoulder referral. Only ruptured ectopic pregnancy adds shoulder pain and signs of falling blood volume, which is why it demands the fastest response. Faintness, a rising pulse, and pallor reflect the body compensating for lost blood volume. Paired with sudden shoulder pain, this combination means internal hemorrhage, not a muscular complaint. Applying heat, offering food, or encouraging walk-in or treat where the pain is felt instead of where it originates. And each one costs time the client doesn't have. When shoulder pain appears alongside pelvic pathology, the reasoning must root straight to the diaphragm and prepare for surgery, because referred pain always points back to its true origin. Question 6. A nurse is caring for a client during the first stage of labor and notes the bladder is distended. Why is it important for the nurse to address this finding? Your options are: A. It has no effect on labor. B. It prevents bloody show. C. A full bladder can impede fetal descent. D. A full bladder speeds dilation. Which would you go with? Lock it in before the reveal. The correct answer is C. A full bladder can impede fetal descent. C is correct because a distended bladder can block the descent of the fetus and slow labor. So the nurse encourages frequent voiding to keep the bladder empty. A is wrong because a full bladder does affect labor by impeding fetal descent. B is wrong because bladder fullness is unrelated to the appearance of bloody show. D is wrong because a full bladder slows rather than speeds labor progress. A full bladder isn't just uncomfortable during labor, it occupies the same small, rigid pelvic space the baby needs to descend. And understanding that shared anatomy explains a surprising number of labors that seem to stall for no reason. The bladder sits right in front of the lower uterine segment and upper vagina, in the exact path the fetal head must travel. When it fills, it has nowhere to expand except backward into the space the presenting part needs to descend. Pregnancy and labor make this worse in several ways. Circulating volume and urine production rise. IV fluids add more. An epidural blocks the nerves that signal the urge to void, and pressure from the presenting part further dulls that sensation. The client genuinely does not feel full. This is why separating three ideas matters: dilation, the opening of the cervix, effacement, its thinning, and descent. The downward travel of the presenting part. A distended bladder interferes mainly with descent, so the cervix can look perfect while the station refuses to change. Before delivery, a full bladder blocks descent. After delivery, it prevents the uterus from contracting down to control bleeding. Recognizing it as a mechanical problem, not just a comfort concern, is what separates catching it from missing it. Question 7. A nurse is caring for a client in the transition phase of labor who feels she cannot continue and wants to push. Which response by the nurse is appropriate? Your options are: A. Offer encouragement and support. B. Explain transition lasts many hours. C. Leave her alone to rest quietly. D. Tell her to push with each contraction. Don't overthink it. Which one feels right? The correct answer is A. Offer encouragement and support. A is correct because transition is the most intense and discouraging phase. So offering steady encouragement and support helps the client cope, while the nurse confirms readiness before pushing. B is wrong because transition is usually short, and telling the client it lasts hours would add to her distress. C is wrong because the client needs presence and support during this difficult phase, not to be left alone. D is wrong because pushing before full dilation can injure the cervix, so the nurse confirms dilation first. Transition is the last segment of the first stage of labor, from about 8 centimeters to complete dilation at 10. It is the shortest part of labor, but also the most intense. The intensity isn't random. The last 2 centimeters demand the strongest uterine work of all of labor, while the descending head presses on the pelvic floor and rectum, generating an involuntary urge to bear down that doesn't wait for the cervix to finish. The behavioral signature is remarkably consistent: irritability, restlessness, nausea, vomiting, trembling, and sudden temperature swings. Most tellingly, clients often announce they cannot continue or want to go home. A statement experienced clinicians read as a sign of progress, not a real request to quit. Picture the cervix stretched almost fully open while the fetal head descends and presses against the pelvic floor and rectum. This is why the urge to push and the final centimeters of dilation can arrive at nearly the same moment. Distress calls for presence, calm coaching, and reassurance that the phase is short. But the urge to push calls for assessment first. Confirm complete dilation before supporting pushing, and if a lip of cervix remains, coach breathing to blunt the urge until it retracts. Question 8. A nurse is teaching a client at 8 weeks of gestation about warning signs to report during the first trimester. Which finding should the nurse instruct the client to report immediately? Your options are A. Occasional fatigue, B. Mild breast tenderness, C. Vaginal bleeding with cramping, D. Nausea in the morning. Got a guess? Lock it in. The correct answer is C. Vaginal bleeding with cramping. C is correct because vaginal bleeding with cramping in early pregnancy can signal miscarriage or an ectopic pregnancy. So the client should report it right away for prompt evaluation. A is wrong because fatigue is a common and harmless first trimester complaint rather than a danger sign. B is wrong because breast tenderness is an expected early change from rising hormones and does not require urgent reporting. D is wrong because morning nausea is typical in early pregnancy and is concerning only if it becomes severe and persistent. The first trimester carries the highest background risk of loss, and it's also when a misplaced implantation reveals itself. That's why teaching a client which sensations to ignore and which to report is one of the most valuable parts of early prenatal care. Most early discomfort is hormonal, not dangerous. Rising progesterone relaxes smooth muscle, slowing the gut and causing fatigue. Rising HCG correlates with nausea, and estrogen and progesterone together stimulate breast tissue, producing tenderness. These are signs of a functioning pregnancy, not warnings. Bleeding means tissue has separated somewhere. In miscarriage, the sac detaches and the uterus cramps in response. In an ectopic pregnancy, implantation erodes a structure not built to hold it, causing one-sided pain with scant bleeding. Bleeding paired with cramping signals separation and uterine activity together, which always warrants evaluation. Effective teaching gives a short, memorable list to report without delay. Vaginal bleeding, cramping or persistent abdominal pain, fever, painful urination, fluid leaking from the vagina, and vomiting so severe nothing stays down. Naming what does not require a call matters just as much so a client isn't alarmed by every normal sensation. Nausea can be miserable and still be benign, while a small amount of blood with mild cramping can quietly signal a tubal pregnancy. The real assessment skill is sorting complaints by what they indicate, not by how strongly they are felt. Question 9. A nurse is teaching a client about the progestin-only mini pill. Which statement by the client indicates correct understanding? Your options are A. I take it the same time daily. B. I can skip a day safely. C. It protects against infections. D. I can take it any time. Which one is it? Pause the video if you need more time. The correct answer is A. I take it the same time daily. A is correct because the mini pill works at a low progestin dose, so taking it at the same time every day is essential to keep cervical mucus thick and prevent pregnancy reliably. B is wrong because A missed or late mini pill quickly lowers protection, so the client should use a backup method if a dose is delayed. C is wrong because the mini pill prevents pregnancy only and gives no protection against sexually transmitted infections. D is wrong because timing is strict with this pill. Varying the hour reduces its effectiveness, unlike the more forgiving combined pill. The progestin-only pill or mini pill contains no estrogen, which makes it safe for breastfeeding clients, older smokers, and those with clotting or migraine history. But that same missing ingredient is exactly why its timing rules are so strict. A combined pill works chiefly by suppressing ovulation, with hormone levels high and steady enough that a late dose doesn't undo protection. The mini pill doesn't reliably stop ovulation at all, so it depends instead on a local, short-lived effect, thickening cervical mucus into a barrier sperm can't cross. Progestin thickens cervical mucus into a dense plug and thins the endometrium, making both sperm passage and implantation less likely. This mucus barrier strengthens within hours of a dose but starts fading before a full day passes, so it must be rebuilt daily. Because the mucus effect fades quickly, the mini pill's on-time window is only about 3 hours, far stricter than the combined pills for giving margin, and a late dose needs backup contraception for the following days. Emergency contraception is different still. A single high-dose intervention that delays ovulation rather than an ongoing method. None of these three protects against sexually transmitted infection. The real teaching point is that pills that look and are taken the same way can behave very differently inside the body. What changes with the mini pill isn't the packaging, but how little room for error it allows. Question 10. A nurse is caring for a client whose lochia returns to a bright red color after progressing to a paler stage. Which complication should the nurse suspect? Your options are a full bladder, B. Normal involution, C. Mastitis, D. Retained placental fragments. Take a second. Which answer would you pick? The correct answer is D. Retained placental fragments. D is correct because lochia that returns to bright red after fading suggests retained placental fragments, which keep the uterus from fully contracting and can cause continued bleeding. A is wrong because a full bladder displaces the uterus but does not cause lochia to revert in color. B is wrong because normal involution shows lochia fading over time, not returning to bright red. C is wrong because mastitis is a breast infection and is unrelated to the color of lochia. Lochia normally moves through a predictable color sequence as the uterus heals, but the real clinical skill isn't memorizing the stages, it's catching when that sequence runs backward. In the first few days, the raw placental site bleeds freely, producing lochia rubra. As vessels seal, it fades to pink-brown lochia serosa, then thins into yellow-white lochia alba as the endometrium finishes regenerating. Retained placental fragments explain why the sequence reverses. If tissue stays adherent, the myometrium can't contract uniformly around the vessels beneath it, so that patch of the placental bed stays open and starts bleeding fresh again. Other complications have their own signature. A full bladder shifts the uterus but leaves lochia color unchanged. Atony causes early heavy bleeding from a boggy uterus. Endometritis announces itself with odor and fever. Only retained fragments specifically reverse the color sequence. The exam tests whether you catch regression, not whether you can list stages in order. A return to bright red after discharge has already faded is never normal. It signals a segment of the placental bed still hasn't closed. Question 11. A nurse is reviewing initial prenatal laboratory results for a client who is Rh negative and not sensitized. Which intervention should the nurse anticipate? Your options are A. Rh immune globulin at 28 weeks, B. Weekly ultrasounds, C. Daily iron infusions, D. Strict bed rest. Before I reveal it, which one do you think is right? The correct answer is A. Immune globulin at 28 weeks. A is correct because an Rh negative client who is not sensitized receives Rh immune globulin around 28 weeks to prevent her body from forming antibodies against Rh positive fetal blood. B is wrong because being Rh negative alone does not require weekly ultrasounds, which are reserved for specific fetal concerns. C is wrong because SC status does not call for iron infusions. that treatment addresses anemia rather than blood type incompatibility. D is wrong because RH status does not warrant bed rest, which is used for conditions such as preterm labor or bleeding. R factor is a protein that red blood cells either carry or lack. When an Rh negative mother carries an Rh positive fetus, a mismatch arises, creating the one obstetric scenario where a mother's immune system can be primed to attack her own child. Small breaches in the placenta, especially at delivery, let Rh positive fetal cells slip into the mother's bloodstream. Her immune system treats that protein as foreign and starts making antibodies, a permanent change called sensitization. Sensitization rarely harms the pregnancy that caused it, because antibody levels build too slowly to matter the first time. The danger falls on the next Rh positive pregnancy, when antibodies cross the placenta and destroy fetal red cells, risking severe anemia and even fetal death. Rh immune globulin is passive immunization, ready-made antibody that clears fetal cells before the mother's own immune system can respond. It's given around 28 weeks, again within 72 hours of birth if the baby is Rh positive and after any event risking blood mixing, but only if she is Rh negative and not yet sensitized. Don't confuse Rh incompatibility with ABO incompatibility, which involves naturally occurring antibodies, can affect a first pregnancy, and has no preventive injection, or with anemia of pregnancy, which is simply corrected with iron. Question 12. A nurse is caring for a client during the second stage of labor. Which finding indicates that birth is near? Your options are expulsion of the placenta, B, onset of the latent phase, C, bulging of the perineum, D, cervical dilation of 3 centimeters. What's your answer? Commit to one before I continue. The correct answer is C, bulging of the perineum. C is correct because bulging of the perineum and crowning of the head indicate the fetus is descending and birth is near during the second stage of labor. A is wrong because the placenta is expelled in the third stage after the newborn is born. B is wrong because the latent phase is the early part of the first stage, not a sign that birth is near. D is wrong because dilation of 3 centimeters occurs in the first stage, well before birth. Once the cervix reaches complete dilation, labor enters a new stage entirely, the pushing stage, which ends only with the birth of the newborn. During the first stage, contractions do the work alone and pushing adds nothing useful. But once the cervix is fully dilated, contractions alone can no longer complete the descent. So voluntary bearing down becomes both safe and necessary. As the head descends, the perineum bulges and flattens, the anus may dilate, and the labia part. At the peak of a contraction, scalp becomes visible at the introitus, this is crowning, and once the head stops receding between contractions, birth is only a matter of contractions away. The real test is sorting findings by stage. Cervical dilation belongs to the first stage. Placenta delivery belongs to the third stage, and latent phase onset opens the first stage. Only bulging perineum with crowning belongs to the second stage and signals birth is imminent. A bulging perineum with visible, non-receding scalp is a direct mechanical sign that the fetal head is occupying the outlet, unambiguous proof that birth is close, prompting the team to prepare the delivery table and warmer. Question 13. A nurse is teaching a client about latex condoms as a contraceptive method. Which client statement indicates a need for further teaching? Your options are A. I can use baby oil as lubricant. B. Condoms help protect against infections. C. I will check the expiration date. D. I will leave space at the tip. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. I can use baby oil as lubricant. A is correct because oil-based products like baby oil weaken latex and cause it to break. So the client needs only water-soluble lubricants, signaling that the statement requires correction. B is wrong because latex condoms do reduce transmission of most sexually transmitted infections, making this an appropriate understanding rather than an error. C is wrong because checking the expiration date is correct teaching, since an expired condom is more likely to tear and fail. D is wrong because leaving an empty space at the tip creates a reservoir for semen and lowers the chance of breakage, so this statement is accurate. Condoms are the only contraceptive that blocks both pregnancy and infection because they work as a physical barrier rather than a hormone, but that barrier has one specific chemical weakness worth understanding. Natural rubber latex is a network of long polymer chains held together loosely. Nonpolar oils dissolve into that network and force the chains apart, a process called swelling, and a swollen film loses strength within minutes. Picture the polymer chains normally held tight by cross links. Once oil molecules wedge between them, the film thins and weakens dramatically rather than gradually. Baby oil, mineral oil, petroleum jelly, cooking oils, butter, lotions, and massage oils all degrade latex, while water-based and silicone-based lubricants are chemically safe because they never penetrate the polymer network. Lubrication itself is encouraged since it reduces friction-related breakage. The real rule is picking one that's chemically compatible with latex. Reaching for whatever oil is on the shelf is the quiet trap exam writers love to test. Question 14. A nurse is caring for a pregnant client diagnosed with syphilis. Which medication should the nurse anticipate administering? Your options are A. Acyclovir, B. Fluconazole, C. Metronidazole, D. Penicillin G. Which would you go with? Lock it in before the reveal. The correct answer is D. Penicillin G. D is correct because penicillin G is the treatment of choice for syphilis in pregnancy, and it is used even when the client reports an allergy after appropriate desensitization. A is wrong because acyclovir is an antiviral for herpes and is not effective against the bacterium that causes syphilis. B is wrong because fluconazole is an antifungal used for yeast infections, not syphilis. C is wrong because metronidazole treats trichomoniasis and bacterial vaginosis, not syphilis. Syphilis is caused by the spirochete Treponema pallidum, and left untreated it progresses over years from a painless ulcer to a widespread rash, a silent latent phase, and finally cardiovascular and neurologic damage. In pregnancy, the organism also crosses the placenta, making the fetus a second patient. Because the spirochete crosses the placenta so readily, congenital infection can cause stillbirth, preterm birth, and low birth weight, and surviving newborns may show hepatosplenomegaly, a distinctive rash, bone abnormalities, snuffles, jaundice, and later deafness or neurologic injury. That is why every pregnant patient is screened, not just those thought to be at risk. Penicillin G is unique because the spirochete has never developed meaningful resistance, and it is the only drug proven to treat infection in the fetus. Doxycycline and tetracycline are contraindicated in pregnancy due to effects on fetal bone and teeth, and azithromycin reaches the fetus poorly, with documented treatment failures. Because there is no substitute, a reported penicillin allergy does not lead to a different drug. It leads to allergy verification, and if the allergy is real, to desensitization, giving tiny escalating doses under close monitoring until a full therapeutic dose is tolerated, since that managed risk is far smaller than the risk of congenital syphilis. The real skill being tested is matching organism to drug class. Herpes needs acyclovir. Candidiasis needs an antifungal. Trichomoniasis and bacterial vaginosis need metronidazole. but none of them touch a spirit sheet. For syphilis in pregnancy, penicillin G is not just preferred, it is the only option. Question 15. A nurse is assessing a newborn and notes the heart rate. Which apical heart rate should the nurse identify as within the expected range? Your options are A rate of 140 beats per minute, B, a rate of 90 beats per minute, C, a rate of 70 beats per minute, D, a rate of 180 beats per minute. Don't overthink it. Which one feels right? The correct answer is A, a rate of 140 beats per minute. A is correct because a newborn heart rate of about 140 beats per minute is within the expected range, which spans roughly a 110 to 160 beats per minute at rest. B is wrong because a rate of 90 is below the expected range and should be evaluated. C is wrong because a rate of 70 is far too slow for a newborn and requires attention. D is wrong because a sustained rate of 180 is above the expected resting range. Newborn vital signs live in their own world and heart rate proves it best. A resting newborn runs 110 to 160 beats per minute, with 140 sitting right in the middle. That same 140 in an adult would mean significant tachycardia. The reason lies in cardiac mechanics. Output equals stroke volume times heart rate. A newborn's heart is small and stiff-walled, so stroke volume is low and hard to increase, while metabolic demand is high from rapid growth, heat loss, and effortful breathing. With volume unavailable, rate becomes the only compensatory lever. Picture the two hearts side by side. The newborn's chamber is small with stiff walls, producing a low stroke volume, while the adult heart's larger, more compliant chamber can push out much more blood per beat. That structural difference is the entire reason the newborn must lean so heavily on rate, because output falls almost proportionally with rate. A sustained rate below 100 is a resuscitation trigger, not something to watch, while a trained adult athlete's slow pulse is perfectly safe. Sustained tachycardia often signals fever, infection, pain, anemia, or hypovolemia. The real trap is drifting toward adult intuition. 90 or 180 sound unremarkable to adults' ears, but fall outside the newborn band. Always count the apical rate for a full minute in a quiet newborn, since crying and handling inflate the number. Hold heart rate alongside respirations of 30 to 60 and a temperature near 37. And remember, the floor of 110 is where urgency begins. Question 16. A nurse is caring for a client who has postpartum blues on the third day after birth. Which statement by the nurse is appropriate? Your options are A. You should hide these feelings from family. B. These feelings are common and usually pass. C. This means you have a serious illness. D. You will need long-term medication. Got a guess? Lock it in. The correct answer is B. These feelings are common and usually pass. B is correct because postpartum blues are common and usually resolve within about 10 days. So the nurse reassures the client while encouraging her to report feelings that persist or worsen. A is wrong because hiding feelings can isolate the client. Sharing them with support people is encouraged. C is wrong because postpartum blues are a common, self-limiting reaction rather than a serious illness. D is wrong because the blues typically resolve without long-term medication. Postpartum blues is a brief, common mood disturbance affecting many new mothers in the first days after birth, bringing tearfulness, mood swings, irritability, anxiety, and fatigue. The condition has a physiologic basis. Estrogen and progesterone fall precipitously within hours of delivery, one of the steepest hormone withdrawals in human physiology, layered with sleep deprivation, physical recovery, and an abrupt shift in identity. Because the condition is expected and temporary, the correct response normalizes the experience while also naming a threshold for escalation. Encourage her to share feelings with support people, and flag symptoms that persist beyond 2 weeks, deepen, interfere with daily functioning, or involve thoughts of harming herself or the infant. 3 conditions occupy the spectrum, separated by duration and severity. Postpartum blues lasts up to 2 weeks without impairing function. Postpartum depression persists beyond 2 weeks with impaired ability to care for the newborn. And postpartum psychosis is a rare emergency with hallucinations and real risk of harm requiring immediate hospitalization. The skill being tested is calibration in both directions. Telling a client to hide her feelings risks isolation, while calling ordinary blues a serious illness creates needless alarm. So the balanced answer treats it as real, common, temporary, and worth watching. Question 17. A nurse is assessing a client who reports contractions. Which finding indicates the client is in true labor rather than false labor? Your options are A. Contractions ease with walking. B. Contractions that stop with rest. C. Progressive cervical dilation. D. Discomfort felt in the abdomen only. Which one is it? Pause the video if you need more time. The correct answer is C. Progressive cervical dilation. C is correct because true labor produces progressive cervical dilation and effacement, which is the defining difference that separates it from the irregular contractions of false labor. A is wrong because contractions that ease with walking point to false labor, whereas true labor continues despite activity. B is wrong because contractions that stop with rest suggest false labor. True labor contractions persist. D is wrong because true labor pain often starts in the back and radiates forward, not in the abdomen alone. What actually separates true labor from false labor? Not how strong the contractions feel, but what they accomplish. True labor is defined by one thing only: progressive cervical dilation and effacement over time. Not contraction strength, not spacing, not pain severity, not bloody show. Serial cervical exams showing measurable change are what prove labor is underway. The reason cervical change is the criterion is that it's the only proof of effective uterine work. Labor contractions start at the fundus and sweep downward in an organized wave, generating enough sustained tension to retract the cervix. Disorganized contractions can hurt just as much while accomplishing nothing. Secondary clues cluster reliably but never define labor. True labor contractions intensify with walking and are unaffected by rest, hydration, or position change. False labor contractions ease with walking, rest, or a warm shower, and stay irregular in length and interval no matter how much time passes. Lightning, bloody show, back pain, even hours of regular contractions are all suggestive. But none of them confirm labor. Only serial evidence of cervical change does that. Question 18. A nurse is teaching parents about newborn senses. Which statement by the parents indicates understanding of newborn vision? Your options are A. The baby sees clearly across the room. B. The baby prefers dull grey patterns. C. The baby cannot see at all. D. The baby sees best at close range. Take a second. Which answer would you pick? The correct answer is D. The baby sees best at close range. D is correct because newborns see best at close range, about the distance of a caregiver's face during feeding, and prefer high contrast patterns and faces. A is wrong because newborns do not see clearly across a room. Their best focus is close up. B is wrong because newborns prefer high contrast patterns rather than dull grey ones. C is wrong because newborns can see, though their clearest focus is at a short distance. Newborn vision works, but it works within tight limits. And those limits explain a lot about how babies look at the world in their first weeks. The limits are structural. A shorter eyeball, an immature ciliary muscle, a still developing fovea, and an unrefined visual cortex all mean acuity is far below adult levels, though it improves steadily over the coming months. That 8 to 12-inch sweet spot is not random. It is roughly the distance between a newborn's eyes and the caregiver's face during feeding, tuned precisely to the boundaries of hairline, eyebrows, eyes, and mouth that make a face detectable. Vision is the least mature of the newborn senses. Hearing recognizes the maternal voice, smell distinguishes maternal milk, taste favors sweet, and touch is highly developed, which is exactly why vision is the sense most often misdescribed on exams. Hold both truths at once. Newborn vision is present and functional, but it is narrow, tuned to a close, high contrast, face-shaped world. Question 19. A nurse is performing a postpartum assessment and palpates a soft, boggy fundus. Which action should the nurse take first? Your options are A. Massage the fundus. B. Notify the provider. C. Increase oral fluids. D. Document the finding. Before I reveal it, which one do you think is right? The correct answer is A. Massage the fundus. A is correct because a boggy fundus means the uterus is not contracting well, so the nurse massages it first to firm the uterus and prevent hemorrhage. B is wrong because the nurse first corrects the boggy fundus at the bedside with massage before notifying the provider. C is wrong because oral fluids do not firm the uterus and the immediate concern is uterine tone. D is wrong because documenting comes after acting on a boggy fundus that could lead to bleeding. A boggy fundus means the uterus has failed to contract, and that failure is the leading cause of early postpartum hemorrhage. Understanding why massage comes first requires understanding exactly how the uterus normally stops bleeding on its own. When the placenta separates, it exposes spiral arteries that were carrying a huge share of maternal blood flow. These vessels have no clot and no suture closing them, only contracted muscle fibers wrapping around them. The living ligature can compress them shut, so when contraction fails, blood loss can reach a liter within minutes. The nurse must separate 3 findings that each call for a different first move. A soft uterus is a tone problem calling for massage. A firm uterus pushed off midline is a position problem caused by a full bladder. And bright red lochia days later suggests retained fragments needing provider evaluation. Massage is prioritized because a nurse can perform it immediately. It directly reverses the loss of tone, and a uterus that firms under the hand proves it worked. Notifying the provider, emptying the bladder, and escalating to medication all matter, but they follow only if massage alone does not restore tone. When a bedside action can reverse the problem instantly, it comes before calling for help and before charting the event. Question 20. A nurse is caring for a client who has hyperemesis gravidarum and is admitted with dehydration. Which intervention should the nurse anticipate first? Your options are A. Ambulation in the hallway. B. Intravenous fluid replacement. C. Oral iron supplements. D. A large high protein meal. What's your answer? Commit to one before I continue. The correct answer is B. Intravenous fluid replacement. B is correct because severe vomiting causes dehydration and electrolyte loss, so intravenous fluids are given first to restore hydration before food is slowly reintroduced. A is wrong because ambulation does not address the fluid loss that must be corrected first. C is wrong because oral iron is hard on the stomach and is not the priority during active dehydration. D is wrong because a large meal would likely trigger more vomiting. the client is kept without food until vomiting settles. Hyperemesis gravidarum is nausea and vomiting severe enough to cause measurable harm, not just discomfort. The line is crossed when vomiting causes significant weight loss, dehydration, electrolyte disturbance, and ketosis. Ordinary morning sickness is uncomfortable but compatible with adequate intake and stable weight. Hyperemesis means vomiting so frequent that nothing is retained. Intake fails completely, and the problem stops being a symptom and becomes a physiologic derangement. The derangement follows a predictable pattern. Lost gastric acid causes hyperchloremia and alkalosis. Lost potassium causes dangerous hyperkalemia. Lost fluid reduces circulating volume and perfusion. And lost carbohydrate intake forces the body into fat metabolism, producing ketones. Correction begins with intravenous fluid and electrolyte replacement, since the failing gut cannot be the root of repair. Thiamine is given before glucose to prevent a serious neurologic complication, and antiemetics interrupt the cycle. Only afterward is the gut reintroduced, starting with clear liquids and advancing slowly. Nutrition, activity, and iron matter over time, but they won't harm the client in the next few hours. Volume depletion and electrolyte imbalance will, so fluid and electrolyte replacement always comes first. Question 21. A nurse is teaching parents how to care for a circumcision that was done with a clamp procedure. Which instruction should the nurse include? Your options are: A. Scrub the site with soap. B. Give a tub bath today. C. Apply petroleum jelly to the site. D. Remove any yellow film. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Apply petroleum jelly to the site. C is correct because for a clamp circumcision, applying petroleum jelly keeps the diaper from sticking and protects the healing site, and a yellowish film that forms is normal and left in place. A is wrong because scrubbing with soap irritates the healing site. Warm water is used gently. B is wrong because tub baths are delayed until the site heals, with gentle water trickling used instead. D is wrong because the yellowish film is part of healing and should not be removed. Caring for a circumcision wound is ordinary wound care made harder by a hostile environment, constant contact with urine, stool, and a diaper. The right approach depends entirely on which surgical technique was used. A clamp technique, like Gomco or Mogan, leaves a raw, open wound that needs a protective barrier. A ring technique, like Plasterbell, leaves a device that must be left completely alone until it separates on its own within about a week. Within a day or two, a yellowish film forms over the glands. Parents almost always mistake it for pus, but it's granulation tissue, a normal scaffold of fibrin and new capillaries that supports healing and must be left undisturbed. For a clamp wound, petroleum jelly at every change keeps the diaper from tearing the healing surface. Cleaning uses only warm water, since soap irritates granulating tissue and scrubbing causes trauma, and tub baths wait until healing is complete. The key skill is telling healing from infection. A yellow film is expected and should stay, but spreading redness, warmth, swelling, foul odor, fever, heavy bleeding, or a failure to void are the true warning signs that warrant a call. Question 22. A nurse is counseling a client who wishes to become pregnant about preventing neural tube defects. Which nutrient should the nurse emphasize? Your options are: A. Vitamin C, B. Calcium, C. Vitamin D, D. Folic acid. Which would you go with? Lock it in before the reveal. The correct answer is D. Folic acid. D is correct because folic acid is essential for early neurologic development, and adequate intake before and during pregnancy lowers the risk of neural tube defects in the developing fetus. is wrong because vitamin C supports iron absorption and tissue health, but does not prevent neural tube defects. B is wrong because calcium builds bones and teeth, yet it has no specific role in preventing neural tube defects. C is wrong because vitamin D aids calcium use and bone health, but is not the nutrient that guards against neural tube defects. Folic acid, the synthetic form of folate, donates single carbon units that cells need to build DNA and recycle amino acids. Because it's rate limiting wherever cells divide rapidly, nowhere matters more than the earliest weeks of embryonic development. The neural tube starts flat and zips shut along the midline, a process complete by about day 28 after conception. If closure fails at the lower end, the result is spina bifida. Failure at the upper end causes an encephaly, which is uniformly fatal. 28 days after conception is roughly 2 weeks after a missed period, often before a pregnancy test or first prenatal visit. That's why folic acid counseling must happen before conception, not at the first prenatal appointment when the window has already closed. Other nutrients matter too, but they're not interchangeable. Vitamin C supports collagen and iron absorption. Calcium builds fetal bone, and vitamin D governs mineralization, but none of them drive the single carbon transfers that neural tube closure requires. Only folate has that specific job. Folic acid prevents neural tube defects before closure. Alpha feeder protein screening detects an existing defect later in pregnancy, and folate deficiency separately causes megaloblastic anemia. 3 distinct clinical contexts, all tracing back to the same single vitamin. Question 23. A nurse is assessing a client at 30 weeks of gestation who reports regular contractions, low back pain, and pelvic pressure. Which condition should the nurse suspect? Your options are A. Preterm labor, B. Normal fetal movement, C. Round ligament pain, D. False labor. Don't overthink it. Which one feels right? The correct answer is A. Preterm labor. A is correct because regular contractions with low back pain and pelvic pressure before term suggest preterm labor, which needs prompt evaluation to try to stop the contractions. B is wrong because normal fetal movement does not cause regular contractions and rhythmic pelvic pressure. C is wrong because round ligament pain is brief and sharp with movement, not a pattern of regular contractions. D is wrong because false labor produces irregular contractions that ease with rest, unlike the regular pattern described here. Preterm labor is regular uterine activity producing cervical change between 20 weeks and 36 weeks, and 6 days of gestation. 2 elements must both be present: a regular contraction pattern and progressive cervical change. Contractions alone without cervical change are irritability, not labor. Gestational age matters because lung maturity is the pacing item. Type 2 alveolar cells produce surfactant, which lowers surface tension and keeps alveoli from collapsing between breaths. And that supply isn't adequate until late in gestation, so earlier birth risks respiratory distress syndrome. Because outcome improves with each extra week in utero, recognition exists to buy time. Tocolytic medication slows contractions. Corticosteroids accelerate fetal lung maturity. Magnesium sulfate offers neuroprotection. And transfer secures a facility with newborn intensive care. And every one of these requires lead time. The difficulty is presentation. Preterm labor rarely announces itself dramatically. It shows up as a low, dull backache, a sense of pelvic pressure, menstrual-like cramping, and intermittent abdominal tightening, symptoms that overlap heavily with ordinary late pregnancy discomfort. What distinguishes real labor is regularity and persistence, not intensity. False labor eases with rest. Round ligament pain is sharp and movement triggered. And Braxton Hicks lack a progressive pattern. None of them combine regularity with cervical change before term. When they do combine, the window for steroids and transfer is measured in hours. Question 24. A nurse is monitoring a client who has preterm premature rupture of membranes. Which complication is the most common concern the nurse should watch for in this client? Your options are A. Gestational diabetes, B. Infection of the membranes, C. Postpartum depression, D. Iron deficiency anemia. Got a guess? Lock it in? The correct answer is B. Infection of the membranes. B is correct because once membranes rupture early, bacteria can travel upward and cause chorioamnionitis. So infection of the membranes is the most common complication to monitor for. A is wrong because gestational diabetes is a glucose disorder that has no link to ruptured membranes. C is wrong because postpartum depression is a mood disorder that arises after birth, not the immediate risk after early rupture. D is wrong because iron deficiency anemia stems from inadequate iron stores and is not the primary danger when membranes rupture early. Preterm, premature rupture of membranes means the amniotic sac breaks before 37 weeks and before labor begins. Preterm refers to timing before term, and premature refers to timing before labor, and together they define the risk. Intact membranes seal the sterile amniotic cavity off from the bacteria-colonized vagina and cervix, while fluid cushions the fetus and supports breathing movements that drive lung development. Once the membranes rupture, that seal is gone, and the vagina and amniotic cavity become one continuous space. This creates ascending infection, called chorioamnionitis, inflammation and infection of the membranes and amniotic fluid. Risk climbs with the latency period, the time between rupture and delivery, and with every digital cervical exam, since each exam pushes vaginal flora upward, which is why exams are deliberately limited. Chorioamnionitis affects both patients. The pregnant client can develop fever, tachycardia, uterine tenderness, foul fluid, and risk of sepsis, while the fetus faces pneumonia, sepsis, meningitis, and neurologic injury. Infection can also trigger labor itself, working against efforts to prolong pregnancy for lung maturity. The key exam skill is causal linkage. Only infection follows mechanically from losing a sterile barrier, unlike gestational diabetes, postpartum depression, or anemia, when fever, rising heart rates, and tenderness appear together. That's chorioamnionitis demanding a shift toward delivery. Question 25. A nurse allows a newborn's head to fall back slightly, and the newborn extends and then abducts the arms with fingers fanned. Which reflex should the nurse document? Your options are A. Plantar grasp, B. Stepping reflex, C. Moro reflex, D. Rooting reflex. Which one is it? Pause the video if you need more time. The correct answer is C. Moro reflex. C is correct because asymmetric startle response with the arms extending and then drawing back when the head drops slightly is the Moro reflex, an expected newborn finding. A is wrong because the plantar grasp is the curling of toes when the sole is touched. B is wrong because the stepping reflex is seen when the newborn is held upright with feet on a surface. D is wrong because rooting is head turning toward a cheek touch, not a startle response. The Moro reflex is a whole body startle response present in every neurologically intact newborn, triggered by a sudden head drop, loud noise, or jarring surface. The arms shoot outward, fingers fan open, and then sweep back to the midline in an embracing motion, often followed by a cry. This reflex exists because a newborn cerebral cortex is immature and poorly myelinated, so it can't yet organize deliberate protective movement. Instead, hardwired brainstem and spinal circuits called primitive reflexes step in. And the Moro response is thought to be a leftover clutching mechanism for grasping a caregiver when support suddenly disappears. The reflex's clinical value lies in its symmetry. The signal travels from the brain stem down the cervical spinal cord through the brachial plexus and out to both arms equally. Anything interrupting that pathway on one side, like a fractured clavicle, a brachial plexus injury, or a hemispheric lesion, produces an arm that doesn't fully participate. The distinguishing features are trigger and pattern. A sudden positional change or loud sound causes symmetric extension and abduction of both arms, with fanned fingers, followed by adduction. Persistence beyond 4 to 6 months suggests delayed cortical inhibition, while absence at birth suggests central nervous system depression. Other newborn reflexes are easy to confuse with Moro, but each has its own distinct trigger. Rooting follows a cheek stroke. Palmar grass follows palm pressure. Babinski follows an upward sole stroke. And stepping appears when the newborn is held upright with feet on a flat surface. Matching trigger to response resolves the whole group. Question 26. A nurse assesses a client several hours after birth and finds the fundus is firm but displaced to the right and above the umbilicus. Which action should the nurse take? Your options are A. Lower the head of the bed. B. Massage the fundus vigorously. C. Administer uterotonic. D. Assist the client to void. Take a second. Which answer would you pick? The correct answer is D. Assist the client to void. D is correct because a firm fundus displaced upward and to the side usually means a full bladder, so the nurse assists the client to void to allow the uterus to return to midline. A is wrong because lowering the bed does not empty the bladder that is displaced in the uterus. B is wrong because the fundus is already firm, so vigorous massage is unnecessary and would not fix the displacement. C is wrong because a uterotonic addresses a boggy uterus, not displacement caused by a full bladder. A firm fundus that sits high and off to one side is not a tone problem at all. Firmness proves the myometrium is contracting and hemostasis is intact. So the real issue is location, not strength, and something is pushing the uterus out of place. The bladder sits directly in front of and below the uterus, so as it fills, it expands upward and lifts the fundus higher than the postpartum day predicts. Because the sigmoid colon occupies space on the left, the displaced uterus is pushed toward the right, making elevated and deviated right the classic signature. Postpartum physiology makes this likely. Fluid mobilizes into circulation and diuresis is brisk. IV fluids ran during labor. Perineal pain makes voiding uncomfortable, and lingering anesthesia can blunt the urge to go. A stretched bladder wall means the client can hold a large volume without feeling any need to void. Tone, position, and lochia character are 3 separate variables, and only the abnormal one selects the intervention. A soft fundus calls for massage, but a firm, displaced fundus calls for emptying the bladder. Massage or medication would treat a problem that doesn't exist. A full bladder doesn't just shift the uterus, it can mechanically stop it from contracting down, turning a firm fundus boggy. Assisting the client to void, or catheterizing if needed, corrects position and prevents hemorrhage in one move. Question 27. A nurse is observing a new parent interact with the newborn during the first day after birth. Which behavior should the nurse identify as a sign of positive bonding? Your options are A. Holding the newborn face to face. B. Avoiding eye contact. C. Declining to name the newborn. D. Turning away from the newborn. Before I reveal it, which one do you think is right? The correct answer is A. Holding the newborn face to face. A is correct because holding the newborn face to face with eye contact is a positive bonding behavior, showing the client is engaging with and claiming her newborn. B is wrong because avoiding eye contact is a warning sign of difficulty bonding. C is wrong because declining to name the newborn can signal weak attachment, not healthy bonding. D is wrong because turning away from the newborn suggests impaired rather than positive bonding. Bonding is the rapid emotional connection a parent forms in the first hours and days, driven by contact and proximity. Attachment is the deeper reciprocal relationship that builds over months as parent and infant learn to read each other. Both are observable through behavior, which is what makes them accessible. Parents typically hold the newborn face to face at 8 to 12 inches, called the in-face position, so eye contact becomes possible. This distance happens to match how far a newborn can see most clearly, especially toward a high contrast pattern like the human face. The infant's gaze rewards the parent, and the parent's face holds the infant's attention, forming a mutual signaling loop. Contact behaviors follow a recognizable sequence: fingertip exploration of the extremities, then palm contact over the trunk, then full arm enfolding against the body, long side touch. Clinicians watch claiming language, like using the newborn's name, noting family resemblances, and speaking directly to the baby. Every bonding behavior sorts into one of two categories: approach or avoidance. Face-to-face holding, eye contact, naming, touching, and talking are approach behaviors. Turning away, avoiding gaze. Declining to name and minimal handling are avoidance. But a single instance isn't proof, since pain, exhaustion, or grief can cause transient signs, so the pattern over time is what matters. Support the process with skin-to-skin contact, rooming in unhurried time, and involving partners and siblings, while remembering that timing and style vary across families, and difference is not impairment. Question 28. A nurse is teaching parents about safely storing expressed breast milk for their newborn at home. Which instruction should the nurse include in the teaching? Your options are: A. Microwave the milk to warm it. B. Thaw frozen milk in the refrigerator. C. Shake the milk vigorously. D. Refreeze any leftover thawed milk. What's your answer? Commit to one before I continue. The correct answer is B. Thaw frozen milk in the refrigerator. B is correct because frozen breast milk is thawed in the refrigerator to preserve its protective factors, and it is gently swirled rather than shaken before feeding. A is wrong because microwaving destroys protective factors and creates hot spots that can burn the newborn. C is wrong because vigorous shaking can damage components of the milk. Gentle swirling is used. D is wrong because thawed milk should not be refrozen, as this lowers quality and safety. Human milk isn't just nutrition. It's a living fluid packed with antibodies, live white blood cells, enzymes, and growth factors. Every storage and handling rule exists to protect these fragile components because nutrients survive rough treatment far better than immune cells do. Two threats drive every guideline. The first is bacterial growth, controlled through temperature and time limits. The second is destruction of heat-sensitive and shear-sensitive proteins, controlled by how gently milk is warmed and handled. Thawing is where immune components are most easily lost. Moving milk to the refrigerator overnight is the gold standard. Cool to lukewarm running water works when time is short. But the microwave is banned outright, since it creates scalding pockets while destroying immunoglobulins and enzymes. The nuance being tested, convenience and safety point in opposite directions. Microwaving, vigorous shaking, and refreezing all seem like the fast, thrifty choice, but each one damages proteins or invites bacterial growth. Gentle swirling replaces shaking every time. Whenever a question mentions expressing, storing, thawing, or warming breast milk, think immune protection first. The reliably wrong answers are always the microwave, vigorous shaking, and refreezing. Question 29. A nurse is reviewing early indicators of pregnancy with a client. Which finding is considered a positive sign of pregnancy? Your options are: A. Nausea in the morning. B. A positive home pregnancy test. C. Fetal heartbeat heard by the examiner. D. A missed menstrual period. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Fetal heartbeat heard by the examiner. C is correct because positive signs can be explained only by pregnancy, and an examiner hearing the fetal heartbeat is one of those confirmed findings, unlike signs that other conditions can mimic. A is wrong because nausea is a presumptive sign reported by the client and can arise from many non-pregnancy causes. B is wrong because a pregnancy test detects a hormone and is a probable sign, since certain conditions can produce a similar result. D is wrong because a missed period is a presumptive sign the client notices, and stress or illness can also cause it. Signs of pregnancy are traditionally sorted into 3 categories based on diagnostic certainty. This hierarchy exists because most early changes of pregnancy can also be explained by something else entirely. Presumptive signs are subjective changes the client notices, like a missed period or nausea, each with many alternative causes. Probable signs are objective findings a clinician detects, such as uterine softening or a positive hormone test, but they can still be explained by other conditions. Positive signs demonstrate a fetus directly and have no competing explanation. There are only 3 positive signs: an examiner hearing a fetal heartbeat distinct from the maternal pulse, an examiner palpating fetal movement, and visualization of the fetus by ultrasound. Each one demonstrates a fetus directly, which is why nothing else can explain them. Picture a client at 12 weeks with a missed period, nausea, and a positive home test, findings that remain only presumptive and probable. When the examiner places a Doppler on her abdomen and hears a rate near 150 beats per minute, clearly distinct from her own pulse, the finding becomes positive. Presumptive means the client notices it and many things could cause it. Probable means the examiner detects it, but alternatives still exist. Positive means a fetus is heard, felt by the examiner, or seen, and nothing else explains that. Question 30. A nurse is caring for a newborn after a circumcision. How often should the nurse assess the site for bleeding during the first hour? Your options are A. Once before discharge. B. Every 4 hours. C. Only if the diaper is soiled. D. Every 15 to 30 minutes. Which would you go with? Lock it in before the reveal. The correct answer is D. Every 15 to 30 minutes. D is correct because the nurse checks the circumcision site frequently, about every 15 to 30 minutes during the first hour, to catch bleeding early after the procedure. A is wrong because a single check is not enough during the high-risk first hour. B is wrong because every 4 hours is too infrequent to detect early bleeding after circumcision. C is wrong because the site is assessed on a schedule, not only when the diaper is soiled. After a newborn circumcision, bleeding is the complication everyone watches for, and the checking schedule isn't arbitrary. It's built to match the moment when bleeding is actually most likely to happen. Bleeding stops in 2 stages. First, platelets clump into a soft plug within minutes, but that plug is fragile and can be dislodged by pressure or a diaper. Only later does fibrin from the coagulation cascade reinforce it into a stable clot, which is why the earliest hour is riskiest. Newborns also have a transient dip in clotting factors that depend on vitamin K. Little crosses the placenta, breast milk provides little, and the gut bacteria that will eventually make it haven't established yet. So a prophylactic vitamin K shot is given shortly after birth. A scheduled check beats waiting for a soiled diaper because blood wicks into absorbent material without pooling visibly. A newborn's total blood volume is tiny, and a single check before discharge only samples 1 moment out of many. The core idea, assessment frequency should mirror the risk timeline, with the tightest checks in that fragile first hour then gradually spacing out as the clot stabilizes. Question 31. A nurse is teaching a client who will start the contraceptive patch. Which instruction should the nurse include? Your options are A. Apply it to the upper arm. B. Apply it to the breast. C. Reapply after every shower. D. Replace it once a month. Don't overthink it. Which one feels right? The correct answer is A. Apply it to the upper arm. A is correct because the patch is placed on clean, dry skin over areas such as the upper arm, abdomen, buttock or torso, and it can stay on during bathing and swimming. B is wrong because the patch is never placed on the breast, since that site can expose breast tissue to higher hormone levels. C is wrong because the patch is designed to stay in place through bathing and swimming, so reapplying after each shower is unnecessary. D is wrong because the patch is changed weekly for 3 weeks with a patch-free 4th week, not once a month. The contraceptive patch delivers the same estrogen and progestin as combined oral contraceptives, suppressing ovulation, thickening cervical mucus and thinning the endometrium. Only the route of delivery is different, and that difference explains almost everything about how the patch is used. Swallowed hormones pass through the liver first, where a large fraction is broken down immediately, an effect called first-pass metabolism. Transdermal delivery bypasses the digestive tract entirely, so levels stay steadier. Gastrointestinal illness doesn't compromise the dose, and the interval stretches from daily to weekly. Acceptable placement sites are the upper outer arm, the abdomen, the buttock, and the upper torso, always on clean, dry, intact skin free of lotion or oil. The breast is excluded absolutely, because a hormone reservoir placed directly over glandular tissue would expose it to far higher concentrations than the bloodstream ever would. One patch is worn for 7 days and changed on the same day for 3 straight weeks, followed by 1 patch-free week when withdrawal bleeding occurs. Monthly replacement would leave 3 weeks with no hormone coverage, letting ovulation resume, which is why this weekly rhythm is not optional. Adhesion is engineered to survive showering, swimming, and exercise, so the client checks daily that the patch is attached rather than peeling and reapplying it, because it contains estrogen. All the same, clotting and cardiovascular cautions of the combined pill still apply. The route changed, but the hormonal risks did not. Question 32. A nurse is assessing a newborn who has tachypnea, grunting, nasal flaring, and chest retractions. Which complication should the nurse suspect? Your options are A. Mongolian spots, B. Respiratory distress syndrome, C. Physiologic jaundice, D. Normal newborn breathing. Got a guess? Lock it in. The correct answer is B. Respiratory distress syndrome. B is correct because rapid breathing with grunting, flaring, and retraction suggests respiratory distress syndrome, often from a lack of surfactant, and requires prompt support. A is wrong because Mongolian spots are a skin finding unrelated to breathing. C is wrong because jaundice involves yellow skin, not respiratory distress. D is wrong because these labored breathing signs are abnormal, not normal newborn breathing. Respiratory distress syndrome of the newborn is a mechanical problem, not enough surfactant to keep tiny alveoli open. Understanding the physics behind that failure explains every sign you see at the bedside. Surfactant made by type 2 alveolar cells lowers surface tension at the air-liquid interface. Without it, small alveoli generate higher collapsing pressure than large ones, so they empty into neighbors and collapse completely, a state called atelectasis. In a healthy lung, residual air stays behind after exhaling, so the next breath takes modest effort. In a surfactant-deficient lung, every alveolus collapses, So each inspiration must reopen it from nothing, exhausting the infant and worsening hypoxia in a self-feeding loop. Tachypnea compensates by increasing minute ventilation. Nasal flaring lowers airway resistance, and retractions appear because a soft newborn chest wall caves under strong inspiratory effort. Grunting is the cleverest of all. A partially closed glottis traps air on expiration, generating the infant's own positive end expiratory pressure. Newborn breathing is normally irregular with occasional pauses, but grunting, flaring, and retractions are effort signs that are always abnormal. Recognizing them as the lung's own attempted treatment is what points straight to surfactant deficiency. Question 33. A nurse is assessing a newborn after a difficult birth and notes limited movement of one arm with an absent reflex on that side. Which complication should the nurse suspect? Your options are A. An expected sleep position, B. A skin pigmentation finding, C. A birth injury to the arm, D. Normal newborn posture. Which one is it? Pause the video if you need more time. The correct answer is C. A birth injury to the arm. C is correct because limited movement of one arm with an absent reflex on that side suggests a birth injury, such as a fractured clavicle or nerve injury, which the nurse reports for evaluation. A is wrong because a sleep position does not cause an absent reflex on one side. B is wrong because this finding involves movement and reflexes, not skin pigmentation. D is wrong because normal posture is symmetric, with both arms moving and reflexes present. Two common birth injuries of the shoulder and arm look nearly identical at the bedside, and both are caught by the same clue, asymmetry. The mechanism is mechanical force on the shoulder girdle as it passes through the pelvis. Most often during shoulder dystocia, traction to free the impacted shoulder transmits force through the clavicle and the brachial plexus, and risk rises with large fetal size, maternal diabetes, a prolonged second stage, operative vaginal delivery, and breech extraction. A fractured clavicle is the most common birth fracture, causing reduced arm movement and sometimes a palpable irregularity, and it heals quickly. Brachial plexus injury is more serious. Stretch in the upper nerve roots causes herb palsy, with the arm adducted, internally rotated, elbow extended, and wrist flexed, while grasp stays intact because the lower roots are spared. The Moro reflex should be equal on both sides, since its pathway runs through the plexus on each side. If one arm fails to respond while the other does, something has interrupted that limb, whether from fracture, nerve injury, or both, making this the most sensitive bedside screen available. Newborns naturally favor positions and postures, and that's normal as long as movement capacity is equal on both sides. But a reflex present on one side and absent on the other is never a normal variation. It's the signal of birth injury, and a newborn exam is largely a search for asymmetry. Question 34. A nurse is teaching a client who has preeclampsia and is on bed rest at home. Which position should the nurse recommend for resting? Your options are A. Sitting fully upright, B. Flat on the back, C. Lying face down, D. Lying on the side. Take a second. Which answer would you pick? The correct answer is D. Lying on the side. D is correct because side lying improves blood flow to the placenta and kidneys and helps lower blood pressure, so it is the recommended resting position in preeclampsia. A is wrong because sitting fully upright does not improve placental perfusion the way the side-lying position does. B is wrong because lying flat lets the uterus compress a major vessel, which can lower blood pressure and reduce placental flow. C is wrong because lying face down is neither comfortable nor practical in pregnancy and does not aid blood flow. Positioning in late pregnancy isn't about comfort. It's a hemodynamic intervention centered on one large vessel, the inferior vena cava. When a pregnant client lies flat, the weight of the uterus presses the vena cava against the spine. Venous return falls. Cardiac output drops, and the aorta can be partially compressed too, reducing pressure to the uterus. The result is a recognizable picture called supine hypotensive syndrome. Hypotension, dizziness, pallor, nausea, sweating, and air hunger. The placenta has no order regulation, so uterine artery pressure translates almost directly into fetal oxygenation. Turning the client onto her side removes the uterus from the vessel, restoring venous return, cardiac output, and blood flow to the uterus and kidneys. Side lying improves renal perfusion too, which is why it's especially valuable in preeclampsia. Remember, in late pregnancy, lying flat is the specifically harmful position, not a neutral starting point. Question 35. A nurse is teaching a pregnant client about food and pet safety to prevent toxoplasmosis during pregnancy. Which instruction should the nurse include in the teaching? Your options are A. Avoid changing the cat litter box. B. Eat meat cooked rare. C. Keep handling raw meat often. D. Skip washing fresh produce. Before I reveal it, which one do you think is right? The correct answer is A. Avoid changing the cat litter box. A is correct because toxoplasmosis can spread through cat feces, so the client avoids changing the litter box during pregnancy to reduce the risk of infecting the fetus. B is wrong because undercooked meat can carry the organism, so meat should be cooked thoroughly rather than leave rare. C is wrong because frequent handling of raw meat increases exposure, which is the opposite of safe practice. D is wrong because washing produce removes possible contamination, so skipping it would raise the risk. Toxoplasma gondii barely bothers a healthy adult, but in pregnancy it crosses the placenta and can severely damage a developing fetus. Because maternal illness is often silent and fetal harm can be devastating, the entire strategy is prevention, not detection. The cat family is the only definitive host, meaning the parasite sexual stage happens exclusively in feline intestine. An infected cat sheds oocysts for weeks. These need a day or more to mature, but then survive in soil, sand, and water for months, while grazing animals like pigs, sheep, and deer pick them up and form tissue cysts in their meat. Humans get infected two ways: ingesting oocysts through cat litter, garden soil, sandboxes, or unwashed produce grown in contaminated soil, or eating undercooked meat harboring tissue cysts, especially pork, lamb, and venison, plus cross-contamination from handling raw meat. Prevention follows the roots exactly. Someone else handles litter, emptied daily so oocysts stay non-infectious. Meat is cooked thoroughly, never rare. Hands, surfaces, and produce are washed carefully, and gloves are worn for gardening. The cat itself is not the danger. An indoor cat eating commercial food stays low risk, so it never needs to be given away. The tested nuance is that 3 commonly offered practices are exactly backwards: eating rare meat, handling raw meat often, and skipping produce, washing all increase exposure. Only avoiding litter box duty truly reduces risk. Question 36. A nurse is reviewing an elevated maternal serum alpha fetoprotein result with a client. Which condition does this finding most suggest? Your options are A. Gestational diabetes, B. A neural tube defect, C. Down syndrome, D. A molar pregnancy. What's your answer? Commit to one before I continue. The correct answer is B. A neural tube defect? B is correct because a high maternal serum alpha fetoprotein level is associated with neural tube defects such as spina bifida, so an elevated result prompts further evaluation of the fetus. A is wrong because gestational diabetes is detected through glucose testing and is unrelated to the alpha-fetoprotein level. C is wrong because Down syndrome is linked with a low alpha-fetoprotein level, not an elevated one. D is wrong because amolar pregnancy is identified mainly by very high pregnancy hormone levels and ultrasound, not a high alpha-fetoprotein. Alpha-fetoprotein is the main plasma protein circulating in the fetus, made by the fetal liver and yolk sac. Small amounts normally leak into amniotic fluid and then maternal blood, giving us a measurable, predictable curve to screen against. The test is drawn between 16 and 18 weeks, and the result is compared against the expected value for that exact gestational age, because the reference range shifts week by week. Incorrect dating is the single most common reason for an abnormal result. An elevated level most often means fetal protein is escaping through a defect that is not covered by skin. Open spina bifida and anencephaly let protein pour directly into amniotic fluid, and abdominal wall defects like gastroschisis and omphalocele raise levels the same way. The direction of the abnormality selects the differential. A high value points to an opening in the fetal body or a multiple gestation, while a low value points to a chromosomal abnormality like Down syndrome or overestimated dating. An abnormal result never diagnoses anything on its own. It triggers confirmation of dates, detailed ultrasound, and sometimes amniocentesis. Keep the direction straight. High suggests an open defect, low suggests a chromosomal abnormality. Question 37. A nurse is caring for a client who is breastfeeding and reports sore, cracked nipples. Which instruction should the nurse provide? Your options are A. Limit feedings to once daily. B. Allow the newborn to suck the nipple tip. C. Ensure the newborn latches onto the areola. D. Apply rubbing alcohol after feeds. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Ensure the newborn latches onto the areola. C is correct because a correct latch with the newborn taking in much of the areola, not just the nipple tip, prevents and relieves sore, cracked nipples during breastfeeding. A is wrong because limiting feedings can lead to engorgement and does not heal the nipples. B is wrong because sucking only the nipple tip causes trauma and worsens soreness. D is wrong because alcohol dries and irritates the skin, making cracked nipples worse. Nipple pain during breastfeeding is almost always a mechanics problem, not a skin problem. Milk moves by compression of the ducts, not suction on the nipple. So when the mechanics are right, the nipple simply isn't the working surface. In a proper latch, the nipple sits deep near the junction of the hard and soft palate, cushioned by the areola, while the tongue's wave-like motion compresses the ducts. In a shallow latch, only the nipple tip is caught between tongue and hard palate, dragging across an unyielding surface with every suck, causing cracking, blistering, and inefficient milk transfer. A good latch shows concrete observable signs: a wide open mouth with lips flanged outward, the chin touching the breast with the nose clear, rhythmic movement of the jaw and temple, and slow deep sucking with audible swallowing. Tugging without pain is normal. Pain itself signals the latch needs fixing. Correction is technique, not products. Break the seal with a finger and relatch with the mouth wide over the areola. Align the infant's ear, shoulder, and hip toward the breast, and keep feeding frequently rather than restricting it. Expressed milk or lanolin support healing, while alcohol and harsh soap strip protective oils and make cracking worse. A cracked nipple looks like a skin injury, tempting a topical fix and less feeding, but both responses fail. The tissue is being injured mechanically every few hours, so only correcting the latch actually stops the harm. Question 38. a nurse is caring for a client who has eclampsia and begins to have a seizure. Which action should the nurse take first? Your options are A. Restrain the client's arms, B. Leave to call the provider, C. Insert an oral airway, D. Turn the client to the side. Which would you go with? Lock it in before the reveal? The correct answer is D. Turn the client to the side. D is correct because turning the client to the side during a seizure keeps the airway clear and lets secretions drain, which protects breathing and is the priority safety action. A is wrong because restraining the limbs can cause injury. The nurse protects the client from harm without holding them down. B is wrong because the nurse stays with the client to maintain safety and the airway, rather than leaving during the seizure. C is wrong because forcing an airway into the mouth during active seizing can injure the client and is not done first. When a preeclamptic client seizes, every clinical priority collapses into one concern: protecting the airway. During the tonic phase, respiratory muscles contract rigidly, so ventilation stops. Consciousness is lost, protective reflexes fail. Saliva pools and gastric contents may be regurgitated, all while fetal oxygenation falls alongside the mother's. Turning the client onto her side is the first action because it solves multiple problems at once. It drains secretions away from the airway, moves the tongue off the pharyngeal wall, and relieves vena cava compression to restore blood flow to the placenta. Restraining limbs doesn't stop a seizure and causes fractures, while forcing objects into a clenched mouth breaks teeth and injures the airway. Instead, the nurse pads rails, lowers the bed, and stays at the bedside calling for help without ever leaving the client alone. Whenever a stem mentions eclampsia, seizure, or convulsion, remember airway before everything, and lateral positioning is the single action that secures it. Question 39. A nurse strokes the cheek of a newborn, and the newborn turns the head toward the touch and begins to suck. Which reflex should the nurse document? Your options are A. Rooting reflex, B. Tonic neck reflex, C. Babinski reflex, D. Moro reflex. Don't overthink it, which one feels right? The correct answer is A. Rooting reflex. A is correct because turning the head toward a touch on the cheek and beginning to suck is the rooting reflex, which helps the newborn locate the nipple for feeding. B is wrong because the tonic neck reflex is the fencing posture when the head is turned to one side. C is wrong because the Babinski reflex involves the toes fanning when the sole is stroked. D is wrong because the Moro reflex is a startle response to a sudden change in position, not head turning toward touch. Feeding cannot wait for learning, so newborns arrive with a built-in solution to a location problem. Stroking the cheek or corner of the mouth triggers the head to turn toward the touch, the mouth to open, and the tongue to search for something to latch onto. Rooting is one link in a chain of 3 reflexes. Rooting locates the nipple and opens the mouth. Sucking is triggered by contact with the palate and creates rhythmic tongue and jaw motion. And swallowing moves milk safely past the airway once fluid reaches the back of the tongue. All 3 reflexes must be coordinated in sequence. Roughly 1 suck-swallow-breathe cycle per second for oral feeding to work. A preterm infant may root and suck without sequencing them safely, producing choking and oxygen desaturation, which is why feeding readiness assessment looks at coordination rather than just the presence of reflexes. The identifying pattern is a stroke to the cheek or perioral area, producing head turning towards the stimulus with the mouth opening wide. That direction of response, turning toward the touch, is what separates rooting from every other reflex in the newborn exam. The reflex fades by 3 to 4 months as voluntary head control develops, and its absence at birth can suggest prematurity, CNS depression, medication effect, or neurologic injury. Working with routing rather than against it also helps parents achieve a deeper, safer latch. Question 40. A nurse is caring for a client scheduled for an external cephalic version at term because the fetus is in a breech position. What is the goal of this procedure? Your options are A. To start labor immediately. B. To turn the fetus to a head-down position. C. To numb the perineum. D. To deliver the placenta. Got a guess? Lock it in. The correct answer is B. To turn the fetus to a head-down position. B is correct because an external cephalic version uses external manipulation to turn a breech fetus to a head-down position so a vaginal birth becomes possible. A is wrong because the procedure repositions the fetus rather than aiming to start labor right away. C is wrong because numbing the perineum describes a pudendal block, not an external version. D is wrong because the placenta is delivered after birth and is unrelated to turning the fetus. External cephalic version is a procedure where a clinician manually turns a breech or transverse fetus into a head-down position through the maternal abdomen, done around 37 weeks to convert a cesarean-bound presentation into one that permits vaginal birth. The problem is mechanical. The fetal head is the largest, hardest, most evenly rounded part, so it molds to the pelvis and dilates the cervix efficiently. In breech, the smaller, softer buttocks lead first, risking head entrapment and cord prolapse after the body has already passed. The clinician applies firm, steady pressure to lift the breech out of the pelvis while guiding the head downward. Done near a labor and delivery unit with cesarean capability immediately available in case of complications. Timing balances two risks: too early and the fetus may still turn on its own. Too late and shrinking fluid leaves no room. So preparation includes ultrasound to confirm position and fluid, continuous fetal heart monitoring, a tocolytic to relax the uterus, and RH immune globulin for RH negative clients. Remember, this procedure only repositions the fetus. It does not start labor, numb the perineum, or deliver the placenta. Its singular purpose is converting the presentation so vaginal birth becomes possible. Question 41. A nurse is teaching a client who had a vasectomy 1 week ago. Which instruction should the nurse include? Your options are A. Reversal is simple and reliable. B. You are sterile immediately. C. Use another method until sperm clears. D. Avoid all activity for a month. Which one is it? Pause the video if you need more time. The correct answer is C. Use another method until sperm clears. C is correct because sperm remain in the system for a while after a vasectomy, so the client must use another contraceptive method until semen testing confirms that no sperm are present. A is wrong because a vasectomy is meant to be permanent and reversal is a complex, costly procedure that is not always successful. B is wrong because sterility is not immediate. Remaining sperm must be cleared through repeated ejaculations before the procedure is fully effective. D is wrong because most clients resume routine activity within a couple of days, using scrotal support and rest only briefly for comfort. A vasectomy cuts the vas deferens, blocking sperm transport. But understanding why sterility takes time to arrive requires knowing exactly what the small tube does and doesn't touch. Sperm form in the testes, mature in the epididymis, then travel through the vas deferens to mix with fluid from the seminal vesicles and prostate. Cutting the vas blocks that transport, but testosterone, erection, sensation, and ejaculate volume are untouched, since sperm are only a tiny part of the fluid. The tube was cut, but the reservoir beyond the cut was already stocked with millions of viable sperm. Clearing them takes about 15 to 20 ejaculations, or several weeks to a few months, so fertility persists after the incision. Sterility is confirmed by a semen analysis, not by elapsed time, so a backup method is required until that test shows a zoospermia. The procedure is also meant to be permanent. Reversal is possible, but requires microsurgery, is costly, and grows less reliable the longer it's been. The nuance being tested is this mismatch. A cut feels immediate, but the reservoir downstream keeps fertility alive for weeks until testing confirms it's clear. Question 40. A nurse is preparing a client for an epidural during labor. Which intervention should the nurse anticipate to reduce the risk of low blood pressure? Your options are: A. Have the client stand to walk. B. Restrict the client's fluids. C. Place the client flat on her back. D. Give an intravenous fluid bolus. Take a second. Which answer would you pick? The correct answer is D. Give an intravenous fluid bolus. D is correct because an epidural can cause maternal low blood pressure, so an intravenous fluid bolus beforehand helps expand circulating volume and prevent a sudden drop. A is wrong because the client cannot safely walk after an epidural, and standing does not prevent the blood pressure drop. B is wrong because restricting fluids would increase, not decrease, the risk of low blood pressure. C is wrong because lying flat can worsen low blood pressure by letting the uterus compress a major vessel. Epidural analgesia gives excellent pain relief in labor, but its most common significant side effect is hypertension, and understanding why it happens explains how it's prevented and treated. Local anesthetic reaches the smallest, thinnest nerve fibers first. Sympathetic fibers are among the smallest, so they're blocked before the sensory fibers carrying pain, and well before the large motor fibers, causing loss of baseline vessel constriction throughout the lower body. Blocking sympathetic tone suddenly enlarges the vascular container without adding any fluid. Blood pools in dilated leg and pelvic veins, so less returns to the heart, reducing stroke volume and dropping blood pressure, a relative hypovolemia where nothing is lost but the space has grown. Restricting fluids removes the one preventive measure that works. Lying flat adds mechanical vena cava compression on top of vasodilation. And standing to walk is unsafe once motor and sympathetic fibers are blocked, since the legs can't bear weight and pooling is exaggerated. All three deepen the same hypertension. Preloading with IV fluid fills the container before it expands. Lateral positioning prevents added vena cava compression. And frequent blood pressure and fetal heart rate checks catch problems early, because falling maternal pressure translates directly into reduced fetal oxygen delivery. Question 43. A nurse is reviewing the fetal monitor strip and notes the fetal heart rate slows after the peak of each contraction and returns slowly to baseline. How should the nurse interpret this pattern? Your options are: A. Late decelerations. B. Variable decelerations. C. Accelerations. D. Early decelerations. Before I reveal it, which one do you think is right? The correct answer is A. Late decelerations. A is correct because a heart rate that dips after the contraction peak and returns slowly is a late deceleration, which suggests the placenta is not delivering enough oxygen to the fetus. B is wrong because variable decelerations are abrupt and vary in timing, unlike this consistent dip after the peak. C is wrong because accelerations are brief increases in the heart rate, not the decreases described here. D is wrong because early decelerations mirror the contraction and are caused by head compression, a benign finding. Fetal heart rate decelerations are classified by their timing relative to contractions, and that timing is not incidental. It directly reveals what mechanism is causing the heart rate to fall. During a contraction, spiral arteries feeding the placenta are compressed, so blood flow drops. If placental reserve is inadequate, fetal oxygen tension falls, chemoreceptors sense it, and a reflex slows the heart rate, but only after a delay, which is why the dip lags behind the contraction instead of mirroring it. Early decelerations mirror the contraction exactly and reflect benign head compression during descent. Variable decelerations are abrupt and unrelated to contraction timing, caused by cord compression. Late decelerations lag behind the contraction and signal uteroplacental insufficiency, while accelerations indicate a healthy, well-oxygenated fetus. Because late deceleration stem from reduced placental perfusion. Every intervention aims to restore blood flow. Repositioning relieves vena cava compression. Stopping oxytocin lengthens recovery time between contractions. Fluids support maternal blood pressure, and oxygen boost available supply. A shallow late deceleration is more worrisome than a deep early one, because significance comes from what the timing reveals about mechanism, not from how far the heart rate dips. Question 44. A nurse is teaching a pregnant client who reports frequent heartburn, especially after large meals and when lying down. Which instruction should the nurse include to help relieve it? Your options are: A. Drink large amounts with meals. B. Eat small frequent meals. C. Lie down right after eating. D. Increase fried foods. What's your answer? Commit to one before I continue. The correct answer is B. Eat small frequent meals. B is correct because small, frequent meals keep the stomach from becoming overly full and reduce the reflux that causes heartburn as the growing uterus presses upward on the stomach. Is wrong because large amounts of fluid with meals add to stomach fullness and can make reflux more likely. C is wrong because lying down soon after eating lets stomach contents flow back upward, which worsens heartburn rather than easing it. D is wrong because fried and fatty foods slow stomach emptying and tend to trigger heartburn, so they should be limited. Heartburn in pregnancy comes from acid moving up into the esophagus, and it becomes almost inevitable because of two separate changes happening at the same time, one hormonal and one mechanical. Progesterone relaxes the lower esophageal sphincter and slows gastric emptying, while the growing uterus compresses the stomach and raises intra-abdominal pressure. Together, these weaken the barrier and push contents upward, which is why symptoms worsen in the third trimester and fade quickly after birth. Picture the sphincter as a loosened gate at the top of the stomach, with the enlarged uterus pressing upward from below, forcing acidic contents through that gate and into the esophagus. Every effective measure reduces stomach volume, reduces pressure, or uses gravity. Small frequent meals cut volume. Staying upright and elevating the head of the bed use gravity. And loose clothing reduces pressure. The trick tested is spotting the inversions. Large fluids with meals increase volume. Lying down removes gravity. And fried foods slow emptying, so only small frequent meals is genuinely correct. Remember that this same smooth muscle relaxation from progesterone also slows the intestines, contributing to constipation, while uterine pressure adds venous congestion behind hemorrhoids, 3 discomforts, 1 shared hormonal thread. Question IoT 5. A nurse is caring for a client in labor who has an external fetal monitor. Which statement about external monitoring is accurate for the nurse to share? Your options are: A. It measures exact contraction strength. B. It can only be placed by a provider. C. It does not require ruptured membranes. D. It requires a fully dilated cervix. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. It does not require ruptured membranes. C is correct because external monitoring is non-invasive and does not require ruptured membranes or cervical dilation, so the nurse can apply it without those conditions. A is wrong because external monitoring shows contraction timing but cannot measure exact contraction strength. B is wrong because the nurse can apply external monitors which do not require a provider to place. D is wrong because external monitoring does not require a dilated cervix, unlike internal monitoring. Electronic fetal monitoring tracks fetal heart rate and uterine activity together, so the two can be compared. It comes in two forms, external and internal, and the difference between them determines when each can be used, who can place it, and how precise the information is. External monitoring uses two belt-held transducers on the abdomen, an ultrasound transducer for fetal heart rate, and a tocodynamometer that senses abdominal wall tightening from contractions. Since nothing enters the body, it requires no ruptured membranes or dilation, and a nurse can apply or reposition it freely. Internal monitoring solves the precision problem at the cost of access. A fetal scalp electrode attaches directly to the fetal scalp for an exact heart rate signal, while an intrauterine pressure catheter sits inside the uterine cavity and measures true pressure in millimeters of mercury. Both require ruptured membranes, adequate dilation, and provider placement. External monitoring is non-invasive, always available, nurse-applied, and approximate, found in Foley. It gives frequency and duration, but not true intensity. Internal monitoring is invasive, conditional on ruptured membranes and dilation, provider-placed and precise, making it the right choice when exact contraction strength truly matters, such as during oxytocin augmentation. Only an intrauterine catheter can measure exact contraction strength, and only internal monitoring requires provider placement and dilation. External monitoring's defining trait is simply that it needs no ruptured membranes at all. Question 46. A nurse is assisting with non-pharmacologic pain relief for a client in labor who has back pain. Which measure should the nurse use? Your options are A. Keep the client fully supine. B. Withhold all touch. C. Encourage rapid shallow breathing. D. Apply sacral counterpressure. Which would you go with? Lock it in before the reveal. The correct answer is D. Apply sacral counterpressure. D is correct because firm sacral counterpressure with the heel of the hand helps relieve the lower back pain many clients feel during labor, especially with an occiput posterior position. A is wrong because the supine position can worsen back pain and lower blood pressure, so it is not used for comfort. B is wrong because therapeutic touch and massage often ease labor pain rather than being withheld. C is wrong because rapid shallow breathing can cause lightheadedness and tingling rather than relieving pain. Back pain in labor isn't random discomfort. It has a specific anatomical cause, and that means it responds to a specific intervention. In an occiput posterior position, the back of the fetal skull faces the mother's sacrum instead of her pubic bone. Every contraction presses that hard bony surface directly into the sacrum and the nerves there, so the pain concentrates in the low back and often lingers even between contractions. Sacral counterpressure works mechanically. Firm pressure from a hand or fist against the sacrum partly offsets the fetal head pushing outward, and the strong sensory input competes with pain signals in the spinal cord, a phenomenon called gate control. Other position changes work the same way, by shifting mechanics rather than dulling sensation. Hands and knees or forward leaning let gravity pull the fetal spine away from the sacrum. Lunges and pelvic rocking widen the pelvis and encourage rotation. And side lying opens the pelvis asymmetrically. Supine positioning presses the sacrum flat against the bed, worsening pain and compresses the vena cava, reducing fetal oxygenation. Comfort measures aren't interchangeable. Back pain in labor calls for firm sacral counterpressure and position change. Question 47. A nurse is caring for a client who had a postpartum hemorrhage and is now receiving oxygen and intravenous fluids. Which position should the nurse use to support circulation to vital organs? Your options are A. Elevate the legs, B. Position prone, C. Keep the head elevated sharply, D. Place in high Fowler. Don't overthink it, which one feels right? The correct answer is A. Elevate the legs. A is correct because elevating the legs helps return blood to the central circulation and supports perfusion of vital organs during recovery from a postpartum hemorrhage. B is wrong because A prone position is not used and does not improve central circulation here. C is wrong because sharply elevating the head reduces blood flow to the brain during low volume. D is wrong because high Fowler can lower blood pressure further during hypovolemia. Postpartum hemorrhage causes hypovolemia, a state where there simply isn't enough blood volume to perfuse the brain, heart, and kidneys. The body compensates in a predictable order, and recognizing that order early is what allows intervention before things fall apart. Heart rate rises first to compensate for a smaller stroke volume. Vessels constrict, making skin cool and clammy. Respiratory rate climbs and urine output falls as kidneys hoard volume. Blood pressure is the last value to change, so a normal pressure in a bleeding client is not the reassurance it seems. Leg veins hold a large volume of blood under low pressure. Raising the legs above the heart lets gravity drain that pooled blood back into central circulation, improving filling, stroke volume, and perfusion of vital organs immediately and temporarily while fluids are prepared. All four positions are real nursing tools, but only leg elevation moves pooled venous blood toward the heart. Sitting upright or steep head-down tilt work against that goal or bring their own costs, and prone positioning blocks assessment of the fundus and airway entirely. Remember that leg elevation serves two different purposes in postpartum care. In hemorrhage, it restores central perfusion, while in deep vein thrombosis, it simply reduces local swelling. Confusing the two is the trap this question is built around. Question 48. A nurse is caring for a client who has a deep vein thrombosis after birth. Which intervention should the nurse include in the plan of care? Your options are A. Massage the leg every hour, B. Elevate the affected leg, C. Encourage prolonged sitting, D. Keep the leg in a dependent position. Got a guess? Lock it in. The correct answer is B. Elevate the affected leg. B is correct because elevating the affected leg promotes venous return and reduces swelling, supporting treatment of a deep vein thrombosis along with prescribed anticoagulants. A is wrong because massaging the leg can dislodge the clot and is contraindicated. C is wrong because prolonged sitting promotes venous stasis and clot formation. D is wrong because keeping the leg dependent increases swelling and venous pooling. Postpartum deep vein thrombosis has a predictable cause, and understanding it explains both prevention and treatment. 3 factors combine after delivery: hypercoagulability, from rising clotting factors that protect against hemorrhage but linger for weeks; venous stasis, from an enlarged uterus; low progesterone-driven vein tone and reduced mobility; and endothelial injury from delivery trauma, cesarean surgery, or inflammation. When a vein is obstructed, blood keeps arriving through the arteries but cannot drain. So pressure builds downstream and fluid pushes into the surrounding tissue. This produces unilateral swelling, warmth, redness, and tenderness. A one-sided picture that separates DVT from the normal bilateral swelling of postpartum recovery. Elevating the affected leg helps gravity drain the congested bed, but it treats the swelling, not the clot. Anticoagulation does that job. Massage is avoided because a fresh clot is loosely attached, and dislodging it can send a fragment to the lungs, causing a life-threatening pulmonary embolism. In hemorrhage, leg elevation restores volume to the whole circulation. In DVT, it drains one congested limb while anticoagulation handles the clot. Recognizing which goal applies is the real test of understanding. Question 49. A nurse is reviewing the vital signs of a client on the first day after birth and notes a heart rate of 56 per minute. How should the nurse interpret this finding? Your options are: A. It requires immediate oxygen. B. It signals hemorrhage. C. It is an expected finding. D. It indicates infection. Which one is it? Pause the video if you need more time. The correct answer is C. It is an expected finding. C is correct because a slow heart rate is a common expected finding in the early postpartum period as the body adjusts after birth. So it does not require intervention. A is wrong because an expected slow heart rate without other symptoms does not call for oxygen. B is wrong because hemorrhage causes a rising heart rate with falling blood pressure, not a slow heart rate. D is wrong because infection typically raises the heart rate and temperature rather than lowering the rate. A slow heart rate in the first days after birth isn't a red flag. It's the expected result of a major shift in circulating blood volume. Understanding why the heart slows down helps explain what's normal and what's not. At delivery, 3 things happen almost simultaneously. The placenta detaches and removes a large, low-resistance vascular bed. The contracting uterus auto-transfuses several hundred milliliters of blood back into the system, and pressure on the pelvic veins is relieved, letting pooled blood return. All of this extra volume flows back toward the heart, increasing venous return and filling the ventricle more completely, since cardiac output equals stroke volume times heart rate. A bigger stroke volume means the heart can beat slower and still deliver enough output, helped along by baroreceptor reflexes and rising vagal tone. This bradycardia is only reassuring when nothing else is wrong. A stable blood pressure, a firm fundus, normal lochia, and the absence of dizziness, shortness of breath, or chest discomfort all confirm the finding is benign. Any of those changes alongside a slow rate demands evaluation instead. Hemorrhage and infection both cause the heart to speed up, not slow down. So a low heart rate in an otherwise healthy postpartum client is evidence against those complications, and within about a week, as diuresis clears the extra volume, the heart rate drifts back to baseline. Question 50. A nurse is assessing a newborn and notes whitish yellow cysts on the gums and hard palate. How should the nurse respond? Your options are: A. Swab the cysts for culture. B. Report a possible infection. C. Withhold the next feeding. D. Reassure parents these are normal. Take a second. Which answer would you pick? The correct answer is D. Reassure parents these are normal. D is correct because whitish yellow cysts on the gums and palate are Epstein pearls, a normal newborn finding that resolves on its own. So the nurse reassures the parents. A is wrong because these normal cysts do not require a culture. B is wrong because Epstein pearls are a benign finding, not a sign of infection. C is wrong because Epstein pearls do not interfere with feeding, so feedings continue. Epstein pearls are tiny, firm, whitish yellow cysts on a newborn's hard palate and gum ridges. They're a completely normal finding present in many healthy babies, and they cause no symptoms at all. During fetal development, the palate forms from 2 tissue shelves that grow together and fuse at the midline. As they fuse, small pockets of epithelial cells get trapped beneath the surface, continue producing keratin, and form a tiny, harmless inclusion cyst. The key distinction is oral thrush. Epstein pearls are firm, discrete, few in number, found on the hard palate and gums, and can't be wiped away, while thrush is diffuse, curd-like, found on the tongue, cheeks, and lips, and leaves a raw base when scraped. This reflects a broader principle. Newborn exams are full of alarming looking but benign findings like milia, Mongolian spots, erythema toxicum, and physiologic jaundice. Recognizing normal variants is just as important a skill as spotting true pathology. The correct nursing response to Epstein pearls is simply to recognize them, document the finding, and reassure the parents no treatment, no cultures, no interrupted feeding needed. That's a wrap on our complete practice review for today. If you'd like to reinforce what we covered today, stop by our website. You'll discover hundreds of free practice questions plus complete in-depth study guides to help you review everything thoroughly. It's a great resource for strengthening your understanding, and you'll find the link right down in the description below. Subscribe for more practice sessions, and good luck on your ATI Maternal Newborn Exam.